Pleasure. Thank you. And I am really delighted to be here. This is, and I say this genuinely, this is one of my favorite places to be. I love coming here with all of the institutions we work with, and I am blessed to be able to work with academic institutions around the country on different projects. This is really one of my favorite places because it is so focused regionally on meeting regional needs, and you don't see that in a lot of other places. So I really love the mission here, so it's absolutely a pleasure for me. So I'm going to talk about strategies and some of the projects that we've been doing looking at how to leverage community assets to improve health and equity in rural communities. You have to say that slowly or it sounds like you're saying health inequity. Couple of things. I'm going to start, I want to give you a little bit of background on NORC because anytime there are students in the room, I'm always thinking about recruiting. We are a great place to work, and I'm going to tell you why. I am going to cover a handful of our projects that I think are of interest. I'm going to start with a project that we are doing, and I'm just going to do little snippets on these. But we're doing a really neat project on market segmentation, health communications. I'm going to tell you a little bit about the rural findings from that. I'm going to tell you about some of our rural health disparities work, and I'm probably going to go into a little too much detail on that, but it helps frame things up. It's kind of negative because we got some challenges in our rural communities. From there, I want to pivot and talk about strengths and assets, and that's really where we're trying to move our work towards. And we're doing some exciting new work for the Robert Wood Johnson Foundation to think about how we leverage strengths, how we leverage assets that we know exist in our rural communities to bring that to bear on improving health in our communities. This picture here, before I get started too much, so when I was at the University of Pittsburgh, I was actually at the University of Pittsburgh at Bradford. I ran University of Pittsburgh's Rural Health Research Center, and the School of Public Health had the forethought to understand that housing a rural center in Pittsburgh might not be the best optics. So they flung me out to their most regional campus, most rural campus, which was on the northwest, in northwest Pennsylvania on the New York border, in the Allegheny Mountains, the upper border of Appalachia. And I got to work with Cattaraugus County, which was right across the border in New York. In Pennsylvania, we don't have local health departments. A lot of my work has been working with local health departments, so I always wanted to do that. So I latched onto Cattaraugus County. They were interesting because they were one of the first rural health departments in the country, and rural health departments, I'd love to talk to you some other time about the history of rural public health. It's a fascinating topic by itself. But public health in rural areas happened about 100 years after public health in urban areas because rural areas didn't need public health because public health at that time was all about sanitation and stopping the spread of infectious disease. In fact, if that was an issue in your urban community, you sent people out to the country where they would be further apart, where they would have clean air. You didn't think you needed public health. Once the dynamic shifted, they started developing health departments in rural communities as a pilot project to see whether you could bring the urban benefits of public health to rural communities. And this was one of those first pilots in 1923. It's funded by the Milbank Fund. And I just love this picture because it's child health is rural wealth, which I think is still a wonderful way to think about rural health today. So a little bit about NORC. I'll go through these quickly. So we are a large not-for-profit research organization. We are affiliated with the University of Chicago, but we're separate from the University of Chicago. It's very confusing. We are essentially a government contractor, so we do a lot of work for federal agencies, but we also do work for foundations, for associations, other state and local governments as well. Our main offices are in downtown Chicago, where we have about 500 people. They do a lot of survey research. I'm in our Bethesda, Maryland office. We have about 170 people in Bethesda. We do the analytic and policy research. We're the ones who really connect to the federal agencies. That's why we're in the DC area. We also have a small office in Atlanta. They do a lot of work with CDC. So dynamic organization, a lot of offices around the country. We cover a lot of different topics. I'm in one of our 3 health departments. Health is our largest area, but we also have economics, labor, justice. We also cover education, a lot of different areas, and we work across departments really well to try to bring the synergies to think across disciplines, across sectors. In our health departments, we do a lot of program evaluation work, a lot of primary data collection. We do some of the largest surveys for the US government, like the National Immunization Survey. Some of you may have used the General Social Science or the General Social Survey, the GSS. That's one that we've done since 1972. So a lot of data collection, a lot of quantitative and qualitative research, both primary and secondary data collection, a lot of program evaluation, a lot of program support. So for example, we do work with the Department of Health and Human Services to help support the rollout of Healthy People 2020 because the federal government doesn't have enough staff themselves. They contract with other organizations to help provide some of that staffing. So those are a lot of the different types of work that we do. I'll hit on a couple of things in our public health research department in particular. I mentioned we have 3 health departments. Public health research works primarily with CDC. We do other agencies as well, but we kind of think about it in 3 buckets. Health sciences does the NIH type research, and then healthcare does the work for CMS looking at payment policy, those kinds of issues. In public health, we do a lot of work with the federal government, with foundations, and a lot with the national associations. I used to work at the National Association of County and City Health Officials. There's also ASTHO, which works with state health departments. There are a lot of those organizations we work with closely. We're currently doing projects with the Association of Schools and Programs of Public Health. This is a sampling. We've done a lot of work in public health workforce, public health financing, looking at the impacts of the Affordable Care Act on how that's impacting the public health system. We're doing a large study now for CDC looking at what happens to women's care after they get coverage through the Affordable Care Act and no longer accessing services through the CDC's breast and cervical cancer program, things like that. We also are the national evaluator for the Public Health Agency Accreditation Program, which has been a big area of focus for us. Won't go through all of them, you can see some of that. And then the last thing I just want to let you know, just as background, this is something I'm very proud of. I have the pleasure of co-directing our NORC Walsh Center for Rural Health Analysis. We are now in our 21st year, so we have a long-standing history of rural health research. The Walsh Center originally started at another organization, Project Hope, and it was brought over to NORC in 2003. We've sustained it and grown it over the years. A lot of our work in rural health is funded by the Federal Office of Rural Health Policy, FORHP, that's in HRSA. They have funded us as a rural health research center over the years, and we have done a lot of the rural health disparities work, some of which I'll tell you about. Our chart book update and our mortality study. We also do some payment policy work there as well. The exploring strategies to improve health and equity in rural communities is the Robert Wood Johnson work I'll tell you about. We do a lot of tribal work. This is another area that falls within rural health, but special populations within rural health. We are currently evaluating a tribal health professions program. We also do tribal work looking at tribal housing and food access. We do a lot of the evaluation work for the Federal Office of Rural Health Policy. That's become our biggest project under our rural health portfolio. And then we have a new project, which I'm just going to touch on a little bit as well. It's funded by the Appalachian Regional Commission, looking at diseases of despair in the Appalachian region. So that's enough about NORC. If any of you are interested in more information, let me know. If any of you want jobs, let me know. So what I want to do is I want to start off by talking a little bit about the American Health Value Survey that we did and how rural Americans think about health. So the American Health Value Survey was really not a rural project. This was funded by the Robert Wood Johnson Foundation as well. A colleague of mine, he's in our California office, Larry Bai. He is an expert in marketing and market segmentation and health communications, and essentially he does research that aligns with how companies market products. So they try to figure out, how do Americans think about our products? Let's segment them into different groups and figure out how we target messages, and in different media outlets we'll have different messages targeted to the populations that we're trying to reach. So he thought, well, we can do this in health as well. And so he fielded this survey, the American Health Value Survey. It was fielded out to 10,000 people, so we got a really good sample. And he came up with these 6 different market segments in terms of how people think about health, largely along the dynamics of personal responsibility relative to governmental responsibility. I'm not going to go into the details of this. This is why I have the reference for you. They published an article in Health Affairs. I think it's really neat work, a lot of implications for health communications, and they're doing a lot of follow-up work on that. What I did want to share with you are the rural findings, and I know there is a lot on this slide, but what's really key here, I've got 2 pages of these. These are all of the questions individual questions within the survey where there were statistically significant differences between how rural and urban Americans responded to these questions. And just to highlight a few things. So first of all, and to me this is the top level question. So the question is framed as compared to other activities, other things going on in your life, how important is health? So how does health compare in importance to other things that you need to take care of? And what we found is that rural Americans place less importance on health. Now again, relative to other things, probably not a surprise. If you are a population that has higher rates of poverty, you're more worried about paying your rent than you are about your personal health. You're more worried about feeding your family than you are your personal health. There may be things that are more important to you than health. So that's kind of the highest level, top level finding. Probably makes sense, has implications for how we communicate. This group, and Dr. Wyckoff and I were talking about this earlier, I don't know what to do with this set of findings, frankly. It troubles me, but I also have some thoughts on probably why it is the way it is. When we ask people about their beliefs in healthcare disparities, we were asking them, compared to whites, do African Americans have an easier time accessing services? Compared to whites, do Latinos have an easier time? Compared to whites, do poor people have an easier time? And across the board, rural people were less likely to think that health disparities existed than non-rural people. Now, I think, this is my theory, just my theory, I think that this is maybe a symptom of some of the divisiveness. You know, when we talk about market segmentation, I think that politics is the true segmenter of populations. Both parties need to identify their group and segment them and tell them that you need to be concerned about other people having something that you should have. I think this is how both parties have tried to succeed and get votes. My hypothesis is that may result in people thinking that, you know, other people don't have it worse than we do. I don't know. But when we think about how do we communicate health, how do we bring populations together, so the reason this is troubling to me is I firmly believe that the solution to a lot of these issues is to think about the health disparities that rural populations face. The main underlying factor is poverty. I'll show you some of that. There are other factors as well, but a lot of it goes back to poverty. When you look at African American populations, Hispanic populations, whatever population you're looking at, that main underlying factor, there are going to be differences as well, but a lot of that goes back to similar root causes. So I think that a lot of these folks have a lot more in common than they do that's different, and there should be an opportunity to bring them together to have a louder voice to say, how do we solve these problems? And if people think that the problem is really just the other person, we're never going to get there. So that's why this is troubling to me. And then the last set, and again, there's a lot more in here, but the last set, and this probably will not be a surprise to people, but again, important to think about in terms of how we communicate. Rural people place less trust and emphasis on government and solving their problems than they do the private sector. I think we all know that, but it's important as we think about how do we market different initiatives. You know, are we going to tell them that, you know, the answer is the Affordable Care Act, this big government initiative? Probably not going to play well in rural areas. Okay, I think that's kind of obvious to us, but you know, I don't know that we always necessarily think about that as we're unveiling these programs. And some of it's just messaging. Some of these programs are public-private partnerships. I think the ones that work best are often public-private partnerships. Well, for rural people, focus on the private side of that partnership. So some things to think about, and I started with this because I want you, as I go through the rest of the presentation, to just keep this in the back of your mind in terms of what does this mean in terms of how we communicate. So what I want to do is I want to get kind of in the weeds a little bit on rural disparities. So some of this is our work, some of this is work that's done by others. This is work that was done by some researchers at HRSA, the Health Resources and Services Administration. And what they did is they tracked life expectancy for metro, for urban, and for rural. And what they found is that there is a growing divide. The disparity between rural and urban has been growing in terms of life expectancy, and that rural has started to plateau. What's interesting about this is that the data that they have stopped in 2009. The most recent data that CDC put out for the first time since 1993 we've actually seen life expectancy in the United States decline. So this is actually as a whole now going down. And back in 1993, the reason for that was the HIV epidemic. A lot of younger people were dying, and that caused life expectancy to decline. Currently, the reason for life expectancy declining is what are being called the diseases of despair. This goes back to work that's being done by Case and Deaton, a couple of health economists at Princeton University. I'll share a little bit more of their work as well. And basically, they have looked at 3 primary causes, which are drug overdose, suicide, and cirrhosis of the liver, all things related to despair, and all things that are disproportionately affecting working class, middle-aged whites. That seems to be the driver of declining health status now. A lot of implications there. So a lot of media attention has gone into this. This is just a series of articles that were published by the Washington Post on this. They've gone article by article by article trying to document this, so it's getting a lot of attention in the popular media. And then this was published by the Washington Post, but this is the Case and Deaton data. This is actually the data that they were able to show, and this is the drug overdose line, and this is 2000 to 2015. This is the cirrhosis of the liver line, and this is the suicide line. And again, you can see these as the 3 primary drivers for the declining life expectancy that we're now currently seeing. So again, why is this? We have to go back to the social determinants of health. This is a framework of the social determinants that is being included in the Healthy People 2020 framework. Economics, education, social and community context, health and healthcare, and neighborhood and built environment. And when you look at each of these, rural populations tend to not fare well. And I've included both the rural information as well as the information for Central Appalachia. But you can see when you look at income, average income for rural counties is about $10,000 less than for urban counties. This is nationally. In Central Appalachia, it's $35,000 as compared to $52,000. Percentage of poverty, children living in poverty, 26% in rural counties compared to 21% in urban counties, 33% in Central Appalachia. Unemployment is interesting because actually, and I frankly am not sure what to make of this data, and I don't know that I necessarily have a lot of faith in this data, but nationally, rural counties have a slightly lower unemployment rate, but not so in Central Appalachia where it's 8.2%. And then in terms of educational attainment, in our rural counties, 16.5% have less than a high school education as compared to 14.7% in our urban counties. Central Appalachia, it's 22.7%, much, much higher. High school diploma only, 36% compared to 32% and almost 40% in Central Appalachia. And bachelor's degree or higher, 17% in our rural counties, 24% in our urban counties, and only 13% in Central Appalachia. So again, a lot of the factors that we know contribute to health disparities are very prevalent in our rural communities and certainly in Central Appalachia. This is a map. This is probably my single favorite map, and I think I show it in every presentation, because to me this tells so much of the story. This is a map of what is called persistent poverty, and this is produced by the USDA. So persistent poverty is defined as counties that have had a greater than 20% rate of poverty in the 1980 census, 1990 census, 2000 census, and 2010 census. So 40 years of poverty. And these are the counties that you find. The dark blue are your rural counties, the light blue are your urban counties. You can see that it's much more rural than urban. But what do you see here? You see basically the outline of every geographically defined region in our country, which is absolutely fascinating to me. So you have Central Appalachia. You have the rural south, which we call the stroke belt. It's largely an African-American rural population. You have the Delta region, all along the Mississippi River. You have the US-Mexico border region, and then all of these dots out here are Indian reservations. This is where poverty lives in our country. Now, there are other places that have poverty. It's not to diminish poverty in other places, but this is persistent poverty. This is where we have 40 years of intergenerational poverty in our country. And guess what? If you overlay any map of health disparities, any condition you want, over this, you're going to get the same map, just about. So this is why I keep saying poverty underlies so much of this. And again, it is across race, across gender, across ethnicity. This is what we see. So I do want to hit a couple of our studies. I'm not going to talk much about this, but I'm going to provide you where to get access to these studies. So this was a study that we did. This was one we were really proud of. We did this through our Rural Health Research Center. We held our Rural Health Research Center as the Rural Health Reform Policy Research Center. It was a collaboration between NORC and the University of North Dakota. When I say that we love to partner with academic institutions, I'm not lying. We did this back in 2014. So some of you may have been familiar with the 2001 CDC report. So CDC every year does their annual Health US report, which is a snapshot of all of the health data on American citizens. So what does mortality, morbidity and mortality look like in our country? 1 year and 1 year only, they did a rural-urban comparison. Every now and then they'll do supplemental pieces to compare different populations. Only time they ever did a snapshot of rural. I found out later that the only reason they did that is that it was funded by the Federal Office of Rural Health Policy, which transferred money to make sure they did that, and nobody had the money to redo that since. So a lot of us in the rural health community were using this as our primary data source to say, look, we got problems in rural areas that need to be addressed, but it, 10 years later was pretty outdated. So we got the Federal Office of Rural Health Policy through our Rural Research Center to fund an update. And I will give CDC a lot of credit. They spent an inordinate amount of time working with us, literally page by page within their 2001 chart book. What were the comparisons? How did you do this? What were the analyses? And we replicated every chart, every graph in that report to do a 10-year update. And it was really done for two primary reasons. One was it was time. We needed a 10-year update. And the second was that this was going to provide a baseline of data prior to implementation of the Affordable Care Act. That was the data we were able to get. So if you want to know whether this is making a difference, here's the baseline. I'm not going to go into the details. We have a ton of charts and graphs. I'm going to show you where you can download that report, where you can access that report. I encourage you to use it. It is national data, though, and that's primarily why I'm not showing it to you is when I go out and present that data to people, people are often frustrated because they're like, okay, so we got a problem nationally, rural versus urban, but rural is not monolithic. We have a lot of different regions in our country, a lot of different rural populations. Telling us that we have a problem nationally doesn't tell me what's going on in my community. So it's useful, but it doesn't get to the full picture. What gets us a little closer was our follow-up study, and I am going to share a tiny bit more information about this. So this was our regional mortality study, and we also did this as part of our research center. And for this, we looked at the 10 leading causes of death for each HHS region, as well as the Appalachian region, as well as the Delta region. So we did this across basically those 12 regions and analyzed the data by level of geography. So we use what are called RUCA codes, rural urban commuting areas, and we break rural down into 5 categories, going from your remote rural to your small town rural to your small metro area, your suburban area, and your large metro area. So all of our data are basically cut that way, and we were able to do this in Tableau. So, and again, I'm going to give you the link to this. You can go into this system, you can create your own maps, you can create your own charts, you can create your own dashboards. It's really a nifty tool, and I'm going to show you, these are the 10 regions. I'm going to show you the dashboard view, and this is males 25 to 64 in Appalachia. You can also do it by age breakdowns. The red boxes basically are where we are finding the diseases of despair. I did want to highlight those for you. But essentially what you see here, the red is the most rural, that's the non-core. The orange is the small town rural. The gray is the small metro. The light green is the fringe, the suburban, and the dark green is your urban. What you see here is that for most of the 10 leading causes of death, rural Appalachia fares worse than urban Appalachia. we see different patterns in different regions around the country. Again, this is why having the national data only takes you so far. But again, across the board, we see some of these fairly dramatic disparities. So for example, 100, for all of these conditions, we've normed them at 100. And basically the way to read this is that this is at 220. So the most rural men in Appalachia have a 2.2 times greater likelihood of dying from lower respiratory disease than men across the nation. Heart disease, 60% greater likelihood of dying. You get into the diseases of despair, unintentional injury, twice as likely to die. So the diseases of despair, unintentional injury is where you find the opioid overdoses. It's not broken out. The problem with that, and I'll talk about this a little bit when I talk about our new ARC project as well, the problem with that is that also includes motor vehicle injuries, which is also a very leading cause of death in and of itself. So that gets mixed together, which isn't ideal. So you see this. And then this is what it looks like for women. Again, unintentional injuries, 2.4 times greater likelihood of dying, lower respiratory disease, 2.6 times greater likelihood of dying. Not a surprise when you see the lower respiratory disease data. Smoking rates are a tremendous problem in rural communities and in Appalachia. When we look across the nation, rural youth are twice as likely to smoke as urban youth. And over the last 10 years, when we did our chart book, smoking rates had gone down for every geographic category in the United States except rural, where they were absolutely stagnant. So smoking is a huge problem. There are other factors that contribute to lower respiratory disease as well, but smoking is certainly the primary one. The other thing I will point out to you in this slide, which has been pointed out to me a couple of times and is kind of alarming and isn't something you'll notice unless you're looking for it, but homicide is the one cause of death nationally that tends to be more of an urban than a rural problem. But look at the homicide rates, and again, you see it in urban. This is homicide rates for men. Look at the homicide rates for women in Appalachia. So if you are a rural woman in Appalachia, you are 60% more likely to die from homicide, which is probably related to interpersonal violence or intimate partner violence. So again, something else that I think isn't getting a lot of attention that may need more attention that jumps out from this data. That's all I'm going to get into in terms of the chart book and the mortality study, but again, I encourage you to dig deeper. I alluded to this. This is our new work, and I can't tell you a ton about it because we are absolutely just getting started on this. But we did do this study back in 2008. I'll show you a tiny bit of data from that as well, where we did the project with the ETSU, and we were able to document the substance abuse and mental health disparities in the Appalachian region. I have been talking to ARC about redoing that study now for probably 5 or 6 years, and it's kind of a frustrating discussion because I think they would like to do it. They just, they're a federal agency. They don't have authority to determine where their dollars get spent. They don't have the money to do it. So we were able to take a little bit of a nibble off the apple with this study, and essentially what we've proposed to them is to follow the work of Case and Deaton, define this as diseases of despair, and to look in the Appalachian region if we can document differences in diseases of despair. The other piece of this that I will tell you is that when ARC funded this, they asked us to give them 3 separate proposals for 3 separate pieces. The first piece, they had the funding, the small amount of funding that they could give to us to do, but they wanted to have add-on pieces to both map the results and then to do a qualitative piece to describe the findings. And they are trying to have CDC co-fund some of that, and they're hoping that that in their next budget they may be able to fund some of that as well. So there may be some opportunities still to move this forward, and the reason I say that is that we partnered with ETSU on that proposal, and as these additional pieces get funded, we're hoping to work with you guys on the qualitative piece to help describe the story behind what we're finding as well. But for this, we're basically operating on 3 hypotheses. The first is that disparities related to diseases of despair are greater within the Appalachian region than the US as a whole. I think that'll be a pretty easy finding to demonstrate. The second is that the Appalachian disparities are driving the national trends, showing rising mortality from diseases of despair. The story that we want to tell here is that the first decline in life expectancy since 1993, if you pull out some of this Appalachian data, maybe it won't be there. That maybe the burden in this region is such that it's actually driving the national declines. Now, honestly, I think you could do that in any region of the country that's having a high burden. It's not going to be unique to Appalachia. The Northeast is having a particularly high burden. You could do the same study there. But if you're the Appalachian Regional Commission and you want to talk about why your work is important, being able to say that is really an important thing. So we always try to think with a policy lens as well. And then the third is that within Appalachia, disparities are concentrated based on Appalachian subregion and economic status. This is a typical way that we do the analysis within the Appalachian region. Is ARC has cut the region into 5 subgroups, so we're able to do it by the 5 subregions. And then every county is tagged with an economic development level. It's a 5-tier level, so we're able to see whether the poorer counties are doing better or worse than the counties that are more affluent. And you can kind of guess the way that's likely to go, but we're able to document some of those findings. The other thing that we added to this at their request, which was not part of our original proposal, we're also going to be doing all of this analysis by geography, so we're going to be looking at it by RUCA code as well. So we're going to be able to talk about the more rural counties within Appalachia as compared to the less rural counties within Appalachia. And then last thing I'll say about this is, I mentioned this, I alluded to this already, that when you look at the leading causes of death, things get grouped together, so we have to unpack them, and we've already gone through the case in DEET and worked to see exactly how they unpacked them. So again, we're comparing apples to apples, and we're able to pull out the overdose deaths from the larger injury-related deaths so that we can separate the accidental overdoses from the intentional overdoses, which would fall into suicide, and we're able to also separate that out from motor vehicle injury and other injury-related deaths. All right, and then I do want to hit just real briefly on a couple of other things because these are things we did with you. So this was a study that we did 2 years ago now, maybe, about 2 years ago. And this was a study that we did for the Appalachian Funders Network. They had asked us to look at childhood obesity in Appalachia, and ETSU was the lead on this project and had us do some of the data analysis. And essentially what we did is because there are no great data on childhood obesity, we tried to look at a lot of, and we did a decent job of looking at childhood obesity directly, I think, but more than that, we tried to look at the disease-related outcomes from obesity to talk about obesity-related disease burden in the region. And we did a combined mortality rate for obesity-related diseases, which included stroke, diabetes, and chronic respiratory disease and heart disease. And we looked at just which counties are above the national average and which counties are below the national average. So we were able to show the overall burden of obesity within the region. So that's just a snapshot, and we've got a much bigger report if you're interested, but that's just a snapshot from that study. And then the study that continues to frustrate me because I want them to refund it. This was from the work that we did back in 2008 with ETSU. And for this study, we looked at data, 5 years of data, 2000 to 2004, primary and secondary and tertiary reasons for individuals seeking care in substance abuse treatment facilities. What was interesting about this study as a whole, this was commissioned by the Appalachian Regional Commission because they thought they had a methamphetamine problem. And we came back to them and said, yeah, there are pockets of methamphetamine that are problems within the region, but did you know you have an opioid problem? And they did not. They were surprised by the findings. We were able to show that opioid abuse within the region as a reason for seeking treatment was twice that for the rest of the nation. And lo and behold, when we separated out the coal mining region of Appalachia, it doubled again. So there was a 4-fold increase in the coal mining region of Appalachia. And what you see in these charts is everyone, it's moving up, it's trending up. It would be really interesting to see where this is today as compared to back in the early 2000s, and I think we probably have a sense for where that is. We also looked at heroin, which was peaking up at this point as well. I didn't include all those slides, but we've got a lot more information. This is available on the Appalachian Regional Commission's website if you're interested in and more on that study, and it's about a 600-page report, so I suggest don't hit print. All right. That's the negative stuff. There's a lot, I know. I want to pivot and talk a little bit about the work we're now doing for the Robert Wood Johnson Foundation. I'm really excited about this. So I'll tell you a little bit about, and I can't speak for RWJF, but I can kind of tell you my thoughts on why they're interested in this. So RWJF is a very large foundation, large funder, interested in health. Their mission is now focused around what they call the culture of health, which is to create a culture in the United States where everyone values health as a primary value, just like they value education or just like they value wealth. You know, whatever we think Americans place highest value on, they want health to be right up there. It's a good vision. How do you get there? So they asked us to do this project as a formative research project to help them think about how they can do this in rural communities. So the foundation has invested most of its work in urban communities, and I think they do that, and I think they would acknowledge this, as most funders do, because guess what? We've got good data in urban communities because there are a lot of people, so we can tell you what the problem is. People are concentrated, so we can design an intervention and plug the money into one place, and we can get outcomes data from a lot of people, so we can tell you whether we were successful or not. It's easier to do work in urban areas. And guess what? We have some disparities in our urban communities as well, so it's not bad work to be doing. So we are looking at common assets. So what is it that's unique about rural across the country where we can have a one-size-fits-all? But we know that's not the case. We know that that generally doesn't work. So what's also different in each rural region? Different but not overwhelming, so you don't want to fund it. So that's kind of the balance we're trying to create through this project. What are the cultural factors that exist and how do those differ across regions? Are there promising strategies that we've seen? Are there specific assets that can accelerate things that are already happening in those communities? Who are the change agents? Who are those partners across sectors, across disciplines that can be engaged? Why haven't things worked in the past? And what are the opportunities for RWJF and other funders to actually engage in this area? This is what the project looks like. This is an ambitious project. We have a 12-month time frame. We are currently in this phase. What we have done so far is we have done an extensive literature review. I'll tell you a little bit about some of the findings from that. We have done dozens of interviews with rural stakeholders around the country. We convened a national gathering of rural-focused organizations and associations from across sectors and disciplines, ranging from the American Legion to transportation to education to health. And we're currently writing that up in an issue brief. From there, and I'll show you the asset map that we've developed. So we've tried to encapsulate this into an asset map. From there, we are going to take this out to 4 diverse regions across the country to say what resonates with you and what's different in your region, so we can bring in some of that regional nuance. We're going to be doing these 4 regional meetings in the upper Midwest, the Delta region, the Northeast, and the US-Mexico border region. And from that, we think we're going to come up with regional asset maps. Those meetings are going to focus at the community level, so we're going to bring together community partners to have a dialogue, and we're going to bring together their regional counterparts to reflect on that dialogue, talk about how they can support the community efforts, but also how that can be exported and translated to other communities. And then we're going to test the findings in regions all over the country. We're going to do 6 more regional meetings where we're going to vet those findings. One of those meetings will be hosted here at ETSU, so we're going to work with you guys again on that. So that's that project. Again, shifting from needs and deficits to assets and capacities to opportunities for action. So we're trying to make this turn to stop talking about how difficult and challenging things are, to really focus on the assets and how those can be leveraged. The literature review, we identified over 300 articles that we summarized, and we were looking for articles in particular that looked at rural assets, best practices, models on how those could be overcome. And we took a framework from McKnight and Kretzman to develop an asset map and really focusing on what assets exist, not the deficiencies. And grounding it in principles of community development. So how can communities come together to engage for action? This is a slight adaptation of the framework, the Meit and Kretzmann framework. So it includes individual assets, which are the assets of the people, and they talk a lot about how the people are the greatest strength within any community. So how do we leverage the assets that exist within the people? The organizational and associational assets are the community assets that are controlled by the community. The community assets are the community assets that are controlled outside the community. So some things it's a little bit of a gray area, and some of them differ. So for example, you may have a locally owned bank, which would be an organizational asset, or you may have a branch of a regional bank, which would be a community asset. So some of those things kind of pop back and forth. And then we added this last layer, which is cultural assets. We think in any rural region, history and culture is so important to that region that we need to make sure that is really embedded in this, and that we view that as one of the assets and strengths that can be leveraged, and that whatever we are doing, whatever we are suggesting within a region in terms of how we create action, how we create movement, is reflective of the culture of that region. Otherwise, it's not going to work. So this is what it looks like, and it is an absolute mess. On the left side, we have the assets that we identified. Again, a lot of the ones between these two groups, it's hard to know kind of which one they fall in. It may vary a little bit by community. And then on this side, we have kind of how we think that plays out in terms of what that asset does. So I'm going to come back to this, because I want this to be part of what I open it up to your discussion and any of your questions. What I want to do before that, though, is I do want to let you know the resources I mentioned. So these are the two big reports where we have documented the disparities. They're both available on our website, walshcenter.norc.org. And the link to the tool that you can manipulate and create your own charts and graphs exists there as well, and that's part of the mortality study. And then the last piece, and I did not talk about this, but I want you to know about this as a resource as well. So for those of you who are not familiar with the Rural Health Information Hub, have any of you used the RHI Hub? All right. Used to be called RAC Online. You may be more familiar with it as RAC. But this is just a good resource to know of in and of itself. It's ruralhealthinformation.org, or ruralhealthinfo.org, I believe. You can Google it. It's housed at the University of North Dakota, and they have a whole team of health librarians who do all kinds of background research, everything rural, one-stop shop. And if you are doing research, if you are writing a proposal, whatever you are doing, if you want somebody to do some of the legwork for you, they have an 800 number and they'll do your background research. They are awesome. On their website, so it wasn't meant to be an advertisement for RHI Hub, on their website is what is called the Community Health Gateway, and that's our project. We've partnered with the Hub to actually host it. But we have done these evidence-based toolkits. We now have 10 of them, so this is a little outdated. We also, I don't know which topics are missing at this point, but we basically have done background research on a number of different important health topics and have talked about how to implement programs and evaluate programs in rural areas. What is the evidence base on the topic, whether it's care communication, oral health, or substance abuse? What is the evidence base? How do we implement a program in our community? And how do we evaluate it so that we can contribute to the evidence base, particularly as this program may play out in a rural community? Because a lot of the evidence may exist, but it may not have been tested in rural areas. So Community Health Gateway, another resource. So that's all I wanted to share in terms of resources. What I wanted to do, though, is have you guys reflect on anything you've heard, but in particular, help me with this Robert Wood Johnson project, which I clearly need help with. In terms of how synergies can be leveraged in rural communities, other resources and assets that we may not have on our asset map, additional partners and collaborators that should be at the table, and any other sectors and disciplines to engage. So with that, I will put that back up, and I will hand it over to you, see if you guys have any questions.